Everybody. At the outset, I would bring greetings from Bangalore and my team in Apollo Hospitals to all of you. And I would like to thank the organizers for giving me the opportunity to speak about the problems and solutions of brachial blocks in sitting position. Now, when I got this topic, I in fact was a bit confused as to what I should be speaking on. But then I clarified, and what I'm going to be talking in the next 10-15 minutes is the problems of having a patient in sitting position for orthopedic surgeries when we give brachial blocks with or without GA. So coming to the outline of my talk, I'll be talking about why we use sitting position, or otherwise what is called as a beach chair position. What are the main problems associated with it, both with general anesthetic and regional, and the solutions to it, and a bit of summary. Now, coming to the sitting position, initially when people started using this position, it was called the barbershop position. But then they thought probably this is not a nice term to have in theaters, so they labeled it as a beach chair position. So here on the left you can see a typical beach chair, which I'm sure most of you would have seen when you've been to one of these wonderful beaches in Goa or anywhere in the country. And this is what we try to achieve when we have patients in this position. Now, the orthopedic surgeons, they prefer different degrees depending on what they are doing. So as a broad idea, the arthroscopic surgeries tend to require more of an angle than the open procedures or the upper arm procedures. So if you're looking at the arthroscopic procedures, they tend to have around 60 to 80 degrees of the inclination, and the open shoulder procedures or even the arm procedures can sometimes be done under supine, but they tend to do with around 20 to 50 degrees of tilt. Now, why do the orthopedic surgeons prefer it? One is it provides excellent visualization when they're doing the arthroscopic work for both the anterior and posterior areas. It's easy to undergo a transition to open shoulder work. So if they have any trouble, they can always open up quite easily. The rotational control of the upper extremity is very good. So they have a free arm, and they have it in very much the anatomical position that the patient would be in. So they have got very good control over this arm. And finally, it can accommodate awake anesthesia much more comfortably for the patient than a lateral decubitus position. Now, coming to the problems, went on Google, went on other places and looked at what are the problems with beach chair, and these things come up. Now, this is the Anesthesia Patient Safety Foundation newsletter, which highlighted beach chair position may decrease cerebral perfusion. Now, this was a very important report because it was associated with 4 deaths. They looked at 4 cases where there were 4 deaths in beach chair position. And then you have other case reports coming out like this, other material in the net which regards to medico-legal stuff. So we got Anesthesia and Law. This is a medico-legal newsletter which goes out, which says no day at the beach, catastrophic injuries in head-up position. So there's a lot of importance given to these neurological injuries in beach chair position, mainly with general anesthesia. So the mechanisms which has been postulated again in the literature are things like venous air embolism. Now this actually looks at a case report where somebody used carbon dioxide, so that is not a practice anymore. The other thing which has been quoted many a times is the absence of classical circle of Willis, leading to hypoperfusion to certain areas of the brain. But the more commonly accepted argument is a decrease in cardiac output which occurs in sitting position, and leading to a decrease in systolic blood pressure, and finally a decrease in cerebral perfusion pressure. Now, this graph shows the physiological changes that will occur in you and me when we sit up. So if we are supine and if we sit up, you will see that the cardiac output drops by around 15%. Then we have got a very significant increase in the systemic vascular resistance, going up to more than 30%, which in turn maintains the MAP, and also in addition to the increase in heart rate. But what happens when you give general anesthesia? Now, this is a graph which shows what happens when you give general anesthesia. The cardiac output drops significantly. So you're looking at around 25% drop in cardiac output, mainly due to the venous pooling. Then the systemic vascular resistance is not going up as much, and therefore this decreases the MAP. Now, all of you who have done sitting position will realize that once you start making the patient sit up, you'll see the significant drop in the blood pressure. Now, this is what's happening inside the body. And this can again cause cardiovascular problems like arrhythmias, asystole. So there are a lot of issues associated with the cardiovascular changes that take place. Coming to the brain perfusion, there are mainly two concepts. Now, this is what is, the first one is what is called as the siphon concept or the closed model. Now, this is the argument which the orthopedic surgeons and also to some extent the anesthetists have in maintaining a blood pressure. In this concept, they argue that there is a continuous column of blood between the arterial and venous limb of the cerebral vasculature. So they say that because there is a continuous column, the gravity effects are same on both the ascending and descending loops, so you no need to correct the blood pressure. So if you measure a map of 70 at the arm, the map is 70 at the brain, and no net change in cerebral blood flow or cerebral perfusion pressure. But on the other side, you got neuroanesthetists who do sitting position cases regularly, and they are of the concept that the blood pressure is not agreeing to the siphon concept. That is, the veins are collapsible, therefore it's not a rigid tube system, therefore the heart has to pump against a pressure gradient. Now, this pressure gradient, I'm sure many of you would remember the physiology. It is exactly 1 millimeter of mercury change for every 1.35 centimeter of height difference. So if we have a map of 80 millimeters of mercury at the arm and 38 centimeters of distance to the frontal lobe, the map at the frontal lobe will be around 51.3. Now, coming to the question of map and what is safe with regards to autoregulation. Now, the old concept of having an autoregulation threshold between 50 to 150 has changed. So please make sure that you have maps of at least 70, and that is the recommended maps of safe limit with regards to lower threshold in autoregulation. Now, how often does this occur? Now, this was a retrospective study which looked at the prevalence of cerebrovascular events during shoulder surgery. The incidence is 0.0042%. So 1 in 25,000 of shoulder surgeries have some kind of a cerebrovascular event. Now, you might think this is rare, but if you look at the number of people flying every day all across the world, it equates to 1 aeroplane crashing every day. So it's 350 deaths every day. So is this small number? It's something that we have to think about when we go back home. And again, this might be just the tip of the iceberg, as recently commented in an editorial in this month's Anesthesiology, that this might be because of the underreporting that is taking place when it comes to catastrophes. I'm sure many of you have had some kind of a critical incident in your practice which you have not felt like reporting, or which you find that it's very difficult to write up and submit as a case report. And this is because of lack of academic intent in people, the uphill struggle to publish case reports, and also medical legal issues associated with these cases. Now, the other problems, again, with the sitting position are the brachial plexus injury. This is because of the stretching that the surgeons exert on the shoulder when they are trying to do the shoulder surgery. So always when you do a preoperative examination, check whether the patient has already got some kind of a brachial plexus injury, because if the patient has some kind of a plexopathy, it manifests with shoulder pain and might lead to a false diagnosis from the surgical side, and hence an arthroscopy. Airway problems are again quite important to keep a note on. Irrigation of fluid in the arthroscopic solution can extravasate and cause airway obstruction, which had occurred in one of our cases and required overnight ventilation. Dislodgement of the tube and other peripheral nerve injuries, including one case report which mentioned even a hypoglossal nerve injury. Now, so what do we do about this, and what is the solution? Now, this is a workshop which took place in New Orleans in 2009. And this was held by the Anesthesia Patient Safety Foundation. So you got eminent people there. You got Professor Stolting, Professor Dumont, and there were neuroanesthetists, orthopedic association presidents. So it was a big meeting which took place to solve this issue of why we are having problems with sitting position. So they came out with some recommendations for best practice. So the first one was that we do not have a reliable non-invasive monitor for safe lower limit of blood pressure. BP should be adjusted to account for hydrostatic pressure gradient, avoid deliberate hypotension, and also consider maximum reduction of only 30% from baseline blood pressure. The other important thing that they came out is they saw that there was a practice of measuring blood pressure in the leg. So they said that NIBP should always be measured in the arm and not in the leg. And if you are using an arterial transducer, the transducer should be level to the level of the tragus. So This was regarding the blood pressure measurement. But the other important two recommendations were that the surgical and anesthesia team should share decision making and consent on blood pressure management. And the surgeon should be educated on the potential risks of this position. So here we are in the regional anesthesia conference. So we can say, oh fine, we got all these problems with general anesthesia. So can we go ahead with only regionals? Now this paper which came out just a couple of months ago looked at the cerebral oxygen saturation. And they had 30 patients who had just regional anesthesia and sedation, and 30 patients who had regional anesthesia and regional anesthesia and later general anesthesia. They saw that the patients treated with regional anesthesia and sedation had almost no cerebral desaturation. So this is a very important take-home message, that if you have a patient who has got just an interscalene block with, of course, supplemented suprascapular or other supraclavicular block, you will not have cerebral desaturation events, but a general anesthetic patient will definitely have desaturation events in approximately around 20 to 30%. But the limitations of using just a regional are that the areas of shoulder that are not anesthetized. All of us cannot guarantee a 100% block all the time. The need for muscle relaxation differs with various surgeries. There's a risk of airway obstruction always when they're using arthroscopic irrigation solution, and also the prolonged nature of the case might make it uncomfortable for the patient to sit in this position for a long time. So just a few images of how to position the neck. Now here we have a position of a neck wherein it is neutral in both the lateral view and also in the AP view. The other important thing as an anesthetist is we should protect the peripheries. So here we have the support removed from the left shoulder, and we have to support the scapula because it can cause musculoskeletal injuries and patient will have severe pain following the operation, which might last for a long time. We have to protect the peripheral nerves at the knee and also make sure that there is some amount of support provided. And the break in the table should be at the level of the buttocks, not at the level of the spine, because then somebody who is sitting prolonged will not be able to sit for prolonged duration, and if under general anesthesia you can cause trauma to that area. So in summary, the incidence of major CNS events is rare when patients undergo shoulder surgeries with brachial plexus block with general anesthesia. The etiology again is unclear, but the accepted theory is with regards to cerebral perfusion pressure. Cerebral ischemia, not injury, is not a rare event if they are undergoing under B chair position. Therefore, consider regional anesthesia as much as possible if the surgeon is willing and the patient is willing. Avoid deliberate hypotension either with general anesthesia or with regional anesthesia. This is something which we have to keep in mind, and maintain a mean arterial pressure as much as possible at baseline. Thank you.
Murli, sorry. Ms. Martha, do we have question time or?